This is the second in our webinar series. This is going to be an overview on MAT and just kind of a description of what we'll go over today. I've got probably 30 minutes worth of material, and then I want to leave time at the end of the presentations for case discussion or discussion of the project in general. I know at this point folks may have some questions regarding it. We're glad to answer those at this time. As we get further into it, I'm sure you guys will have some cases you might want to discuss. I will bring some cases also, and we'll discuss it if there's if there's no one that has a case, just so we can kind of talk about kind of a real life situation. Okay, so I'm going to start sharing my screen. So if folks have a question, again, please use the question Q&A button down below. So let's go ahead and start. So, all right, so we're going to go back to the beginning. Okay, so again, this is going to be an overview, and the outline, we're going to just talk a little bit about the opioid epidemic, which I think most folks are aware of, but just to kind of set the context. We'll talk a little bit about buprenorphine, some of the legal requirements. We'll just touch on phases of treatment, talk about misconceptions about buprenorphine. We'll talk a little bit about our project, and then kind of wrap up. And I got probably 22 slides just to kind of let you know. All right, so back in probably 2012, 2013, the federal government began getting alarming signals regarding the increase in overdose deaths coming into the emergency room. And as they looked into it, it became apparent that many of these deaths, most of them were involving opioids, and kind of further investigation showed that this increase in overdose deaths really corresponded pretty closely with the increased number of prescriptions that had been written by providers. So it's a little bit alarming to me that even though we're 5% of the world population here in the United States, we consume about 70 to 80% of the world's opium supply. There are about 2.5 million folks in the United States that are opioid dependent. That's just a little bit under 1%. And the vast majority of those folks are not currently receiving treatment for it. In 2016, 64,000 folks in the U.S. died of overdoses, and that represents almost a 20% increase from 2015. So a couple of years ago, it looks like maybe there was a little bit of a leveling off in the number of overdose deaths, but it then began rising again, and it will be interesting to see the latest numbers. So in California, we're actually relatively well off in terms of overdose deaths. Here on this slide, we kind of have a description of the prescriptions that are written for opioids. And um, in 2012, we accounted for 12% of the nationwide opioid prescriptions. And that's interesting in that we represent about maybe 12 and a half, 13% of the population. So that's, we're writing them at a slightly lower rate, but not too far off the US average. So in 2015, the number of prescriptions written per 1,000 people, and these are we're about almost 800 per thousand. Now this rate is higher in some rural counties, and that's really where we're having more of a problem here in the U.S. or I'm sorry, in California, and sadly, there are some reservations with as many as 4,000 prescriptions per thousand population. So that's about 5 times as many as in the remainder of California, and you can see it represented graphically by that map. Those are hot spots in the state of California for opioid prescriptions. In terms of opioid deaths, as I mentioned, California is amongst the lowest for opioid overdose deaths in the U.S. at 5.2 per 100,000. However, again, in some of our rural counties, we've got overdose rates that are on par with some of the Appalachian states, and those are the states that have been getting the bulk of the attention. And then there are some zip codes within Indian country, or some zip codes which represent reservations. So in Indian country with rates as high as 100 per 100,000. And just for reference, the state of West Virginia has the highest rate of any state at 45 per 100,000, and some of our zip codes are double that. And I'm going to go ahead and see if there's any questions. Looks like there was a chat. Okay, that is, it's like a welcome from Jeff. So again, if you have any questions, just put them in the Q&A. So at this time, I'll just go ahead and continue. So a little bit about buprenorphine. Buprenorphine was first synthesized in the United Kingdom, and it was really designed to be an opioid that had some of the positive analgesic features of other opioids, but did not have some of the more undesirable side effects. Of course, respiratory depression is kind of the main one and the primary cause of death in folks who overdose. That's as you can see, that quotation is I think that's from one of the original researchers. We don't use whilst very much in the United States, so you can tell that that's British. Human testing began in 1971. It was approved in the UK for injection in 1978, and then they began using a sublingual strip in 1982. In 2000, the US Congress passed the DATA. It's a drug act which basically allowed for the use of buprenorphine in treatment of opioid use disorder, and they developed a kind of a regulatory structure to go along with that, which we'll discuss a little bit further on. So one of the reasons that that data was passed is based on the experience of the other parts of the world, particularly in Western Europe. In the midst of a heroin crisis, France pushed for the prescription of buprenorphine by general practitioners, and they've really threw it open to all practitioners, and really encouraged all of their primary care providers to treat opioid use disorders with buprenorphine. And in fact, about a quarter of all primary care physicians in France do treat opioid use disorder folks, and that's compared with 3% in the US. So we're a little bit behind France in terms of widespread use of buprenorphine for opioid use disorder. And one of the things that was very impressive and led to that 2000 year 2000 legislation was the incredible decrease in overdose deaths that France experienced. This was over, I think it was a decade that it decreased by 80%. And also they found that rates of infection with HIV and hepatitis C also decreased by 75%, as you know, a lot of the opioid overdoses in France are due to injectable heroin. So they had tremendous success there, and our legislators thought, well, why don't we give that a try here? In terms of some of the efficacy research, just kind of a survey of providers who prescribe buprenorphine. They reported an average of 80% in reduction in illicit opioid use, along with significant improvements in people's social and functioning, including employment and you know, having a home and those kinds of other life indicators. A large NIDA, that's the National Institutes of Drug Abuse, sponsored clinical trial demonstrated a very robust improvement in treating opioid use disorder and cravings. Let's see, let me move my. So as you can see there, actually my bar is kind of right in the middle. Let's see if I can. Let me. Okay, I'm just gonna minimize it just for a second so I can see it. So as you can see, the number of opioid-free tests in the different folks that were in the trial. So you had it basically tripled, a little bit better than tripled the number or percentage of folks that had clean urine drug screens. And this is just a graph showing the significant decrease in heroin deaths with buprenorphine and methadone patients. And as you can see, there's methadone had the advantage early because it was really the only game in town since the 70s, actually. And then we started using buprenorphine, and there was a decrease in heroin deaths. No, that is just through 2009. Okay, let's see. So let me go to presentation mode again and next slide. So a little bit more on efficacy. It's a little bit of a paradigm shift for the substance abuse treatment industry in that it's really hard, kind of flies counter to the abstinence only um, um, modalities of treatment that have been in existence for really the last previous uh, 40 years or so. And I see there's a um, hand raised. Let me just go through the slide and I'll address the question. So, um, so the average life expectancy of a heroin user is 35 years. Most studies of long-term recovery in opioid use patients who have gotten out of treatment show 90% relapse rate at 1 year if they are not on some type of medication-assisted treatment. And that's kind of in contrast to relapse rates of 20 to 35% for folks that are on buprenorphine. So it really does improve relapse rates tremendously for folks. And they've even studied this in native populations. There was a First Nation study that showed, number one, that treatment adherence is good. So they had a treatment retention rate of 70%, and if I remember correctly, this was at 2 years also. And then they showed basically a negative urine of 90% at 2 years, which which is pretty good. So just kind of looking at it from an actuarial basis, each year a person is on medication-assisted treatment. It adds an average of 2.5 years onto life expectancy. So that's, kind of a nice thing to be able to tell folks. All right, so let me go ahead and go to questions. Okay, looks like you guys are having a hard time with sound. I wonder if I'm mumbling. I'll try and talk a little clearer, and if that doesn't help, I do have a headset that I can use. So we'll go ahead and try that, but I'll try and speak a little clearer. This is my first day back. In a few days, I've been sick with a respiratory illness. I think it's the smoke primarily that has made me vulnerable to the viruses passing around in the community. So let me know if that doesn't work. Okay, it looks like we've got a couple of things on chat. So let me open the chat. So let's see, I'm not seeing. Okay, looks like losing sound. Okay, let me try, thank you, Julie. Let me go ahead and try my, my headset and see if that works better. So just bear with me a second. All right. Okay. Can everyone hear me? And if you can, let's see. All right. So let's see. if everyone can hear me, let's have folks raise their hand. And that's okay. Looks like Jeff raised his hand. Okay, 2 participants raised their hand. So, okay. All right. So that looks like it's better. Okay, I apologize about that. I've got the air going pretty loudly and powerfully above my head, so that might have been a factor in it. Okay, thanks very much. Let's see, it looks like I have another question. Okay, thank you, Julie. Okay, so let's go ahead and proceed. And so a little bit on the mechanism of action of buprenorphine. So it is a partial agonist, antagonist of the mu-opioid receptor. It's longer acting and therefore is less addictive. There is a principle in addiction medicine that in general, things that are longer acting are less addictive than things that are shorter acting, and that's not always the case. So another factor in addictiveness is crossing the blood-brain barrier, and that's a bit of a factor here as well. But it's found that buprenorphine is much less addictive. As a matter of fact, it has a ceiling effect, and it's been shown that that above 40 milligrams, there's no additional euphoric effect. And so that really, if your patients, try to take, a week's worth in a day, it's not going to do them. They're not going to get any positive reinforcement from that. So therefore, it is less likely that that's going to happen. It's very tightly bound to the mu-opioid receptor, and so it outcompetes all other opiates, and it carries, therefore it carries a lower risk of abuse for other opiates. So if someone's taking buprenorphine regularly and then they try to take an opioid, another oral opioid, or even an injected opioid on top of it, they're not going to get the same type of high that they generally do. So that is again a deterrent to that. Basically, it eliminates that positive reinforcer. The partial agonist element, it yields an anti-craving effect, and let me go to that little cartoon in the upper right hand side. As you can, this is just kind of representation of the partial agonism. As you can see, morphine, it's sitting on the receptor and it's agonizing the heck out of that receptor and stimulating it highly and causing a euphoric effect. Naloxone, as you can see, that's a full antagonist. It's just sitting on that receptor and completely blocking it. And then kind of on that third receptor all the way on the right, you have buprenorphine, which is lightly stimulating the opioid receptor, but is also blocking other receptors from landing on that, or other molecules from landing on that receptor. So generally it's administered once daily, and this is something that I think isn't always followed. The idea behind administering it once daily is to decrease the behavioral reinforcement for compulsive use. We're trying to get away from folks, feeling maybe some anxiety in the afternoon and thinking about taking a buprenorphine. We're trying to really eliminate that type of behavioral pattern. So we really do recommend that all of the buprenorphine is taken at one time, generally in the morning. Um, and I've, you know, I've gotten folks that from other providers that are on twice a day or 3 times a day, and I generally try to have them consolidate all the dose in the morning, and they usually don't have any problem with that. You know, occasionally I do have a couple of patients where they've been stable on it for a long time, and they claim that they have tried it once a day and it, you know, doesn't work well for them. And I've let them do the maybe a BID dosing, but I typically try to get everyone on a once a day dosing. And then as you guys probably know, the compound that we use most frequently is the buprenorphine naloxone agent. The naloxone basically is in there as a deterrent for it being altered and injected. Someone tries to inject it with naloxone in it, they're going to be pretty unhappy. Right. So we're going to talk a little bit about the medical legal regulatory part of it. The Drug Addiction Treatment Act of 2000 that basically that was a legislation that allowed for office-based opioid treatment using buprenorphine, which is really a huge leap forward in treatment of opioid use disorder. Prior to that, since the 70s, there was really only naltrexone, oral or injected, which we'll discuss that in another webinar, but is not optimal for this population. Does have its place though. And then methadone, and methadone has several disadvantages relative to buprenorphine, including that folks on methadone maintenance generally have to present to the program every day, usually early in the morning. They have to be compliant with their program for a long time before they can even take home some for the weekend or longer periods of time. And it's hard for someone to have really what most of us think of as kind of a normal life, you know, with a job and you know, family life, because their life really does still revolve around their opioid treatment. And methadone has several problems on its own. It does not have a ceiling effect, so it does cause increasing euphoria as people increase the dose. So it is addictive, and people can use other opioids while they're on it. So there's a lot of disadvantages with methadone. Okay, so in terms of a provider being able to prescribe buprenorphine, for MDs and DOs, there's an 8-hour training. You can generally get that for free these days, or if it's not free, it's pretty low cost. I think I took my training back 6 or 7 years ago when I was actually in my second training, but the one that I got certified in was 6 or 7 years ago, and that was through the American Academy of Addiction Psychiatry, and that was $50, I think, at the time. And then 2 years ago, Congress passed legislation to allow nurse practitioners and PAs to prescribe buprenorphine, and their training is a little bit more extensive. It's 24-hour training, but still, you know, relatively brief. When a provider is trained, they get a second DEA numbers. So I've got two DEA numbers, my regular one, and then it's sometimes referred to as an X waiver DEA. And the reason for that is they just take the first letter of your regular DEA number and then they replace it with an X. So, so that's sometimes you'll hear X waiver. So it looks like there may be something in the chat function. Okay. All right. So, so there are patient caps. This is one of the ways that we're a little bit different from France. You know, in France, they don't, there isn't the same type of regulations regarding the use of buprenorphine and including they don't have a patient cap. So in the United States, for the first year of having an X waiver DEA provider is limited to 30 buprenorphine patients. The second year they can apply for an increase in their cap to 100, and then most physicians are capped out at 100 patients. If a physician has board certification in addiction medicine, either through the American Board of Addiction Medicine or the new addiction medicine board certification, or board certified through addiction psychiatry, folks can then treat up to 275 patients. All right. So in addition to the medication treatment, it's important for folks to receive psychosocial recovery service. So they're doing something beyond just receiving the medication for their opioid use disorder. It's important to remember that, you know, a lot of times when folks by the time they've made the decision to get treated for their opioid use disorder, a lot of folks have really kind of wreaked havoc with different domains in their life. They may have lost jobs and relationships and burned some bridges. So, you know, that has got a lot of times emotional fallout associated with it. Or they just plain need help in kind of getting things back together. There's also in psychosocial recovery, there's also relapse prevention tools that people can learn that can be used really as an adjunct to the medication to try to ensure recovery long term. There's a pocket guide that SAMHSA produces for MAT of opioid use disorder. It's there on the right. It's a quick guide for clinicians. You can download that from the SAMHSA website. It's really it's a condensation of a kind of a large booklet, and this is, I think the quick guide is maybe, I don't know, 15 pages or something like that. But it does have some information regarding options for psychosocial therapies. And this is just kind of a quote from it, from the quick guide. Pharmacotherapy is rarely sufficient treatment for substance dependence. Physicians should refer patients for psychosocial services. Substance abuse counseling and participation in mutual help groups are necessary for most patients. And one of the requirements of buprenorphine treatment is that you have the capacity to refer folks for psychosocial recovery. Now, most of our Indian health programs have behavioral health departments, so we're really kind of blessed that way that we've got built-in treatment resources for us. You know, if a patient doesn't want to be involved in that, then or say they were a long time patients of behavioral health and maybe finished a course of treatment and taking a break from behavioral health, it's important for them to be still involved in something, and you can refer folks to 12-step, or there's another really great recovery resource called Smart Recovery, and that is it was developed by a psychologist using basically just sound behavioral principles. They've got books, and people can do online support groups. So folks that are very isolated, if they've got access to the internet, they can still participate in recovery. That's called Smart Recovery. You can just Google that, that'll come up. Next, so just a little bit on phases, induction. Um, um, Basically, that's the phase of treatment where you switch patient from whatever their current opioid is, either oral or injected opioid, and you switch them over to the buprenorphine product, and there's actually a process that you want to go through. I'm not going to go through all the details. It's a little bit beyond the scope of this presentation, but basically it's you kind of work closely in that first few days with the patient to make sure that they get the right dosage. It looks like we've got a couple of questions. Let me go ahead and, okay, looks like we had a temporary problem with the sound, and I'm sorry about that. I'll have to do some troubleshooting, see what's going on here. Okay. All right. Basically, one of the important things to make sure that the patient knows prior to induction is that they need to be in mild to moderate withdrawal. For most folks, that means that they had to have stopped using opioids 24 hours prior to induction, and already be in moderate withdrawal. And for methadone, it's a longer period of time, generally 72 hours, but you really do need them to be in some form of withdrawal, or else you can precipitate withdrawal because of that very tight binding that we discussed before. Maintenance phase, this is basically after induction. You find roughly what the patient's correct dose is going to be. You can make some fine adjustments. Sometimes you'll have a person kind of go up, say in your induction to 12 milligrams, and usually goes in 4 milligram, 2 or 4 milligram increments. 12 milligrams, but then they'll say that they're still experiencing some craving that they thought that they could stick out before, and so you'll make that adjustment to 16. Generally, 16 is good for most people. Occasionally, someone might need 24. I don't think I've ever had anyone on the max dose, which is 32. I have had some folks on 24, but I usually try to get folks down to 16 if I can as a maximum. So some misconceptions about buprenorphine. They're common questions. Isn't it just substituting one opiate for another? Well, not really. It's not like a regular opiate in that it's that partial agonist antagonist. So it leads leads to less craving, less compulsive use, a tremendously lower risk of overdose, and can make for a more flexible treatment plan in comparison with methadone. So, the next question might be, well, aren't you still addicted to a medication? Well, yeah, I guess technically you're still addicted to a medication, although it's not really addiction because it's not compulsive use. It's, just like, taking an antihypertensive or, or even a vitamin. It's just something that you do to maintain your health and wellness. And so that I think is generally a misconception. Isn't it just like methadone? And we discussed that previously. No, is the short answer. So some of the recent opportunities regarding buprenorphine treatment, the 21st Century Cures Act was passed in 2016. It was a non-competitive grant to every state in the country, and California, the state of California, their share was 50 million per year for a total of, it was actually a little more, a little bit over 100 million to the state of California, which went to the Department of Healthcare Service Substance Use Division. The DHCS then set aside a specific chunk of funds specifically for Indian country, and we're fortunate that California is the only state in the country to specifically have a tribal MAT grant project, and it was 6.3 million over 2 years, and this was divided up into to 10 contracts that were aimed at expanding access to MAT and addressing some of the associated factors with opioid use disorder. Just a few of the specific grant projects. There was the Two Feathers agency it's a consortium. Actually, no, I'll take that back. It's a nonprofit organization that is administered out of the Big Lagoon Rancheria in extreme northwestern California. I think it's in Del Norte County. They are basically doing kind of a community suicide prevention project, which looks at building resilience in youth through development of identification of culture and using, different traditional games and other traditional cultural touchstones. Another project is the MAT Champions Project. Funds were provided to California Rural Indian Health Board and the California Consortium of Urban Indian Health Programs. And this MAT Champions Project, the goal for that is to provide personnel that would kind of facilitate all things MAT. So our MAT champions are doing a few things. And first of all, I think there's going to be a total of 4 or 5 between those two organizations. So they're going to do things such as distribute naloxone. So that's kind of one of those associated issues. having to do with the opioid epidemic in general. It's not specific to buprenorphine, but just and naloxone is the overdose rescue medication. So so they're helping programs to secure supplies of that. They are going to be helping programs expand their telehealth programs, making telehealth more available to, more readily available to programs and their patients. They're going to be hooking folks up with opioid coalitions. There are regional opioid coalitions in most parts of the state, and the MAT champions will help our health programs to interface and network with those coalitions. There's also hub and spoke system, which is a larger system aimed at the whole of the state. It's and this is probably good to know. The state of California, I mentioned that we received 6.3 million out of their 100 million. Probably the biggest part of that 100 million went to develop the hub and spoke system, and that's basically a system in which the methadone maintenance programs who have been doing opioid use disorders for a long time, they are designated to hubs, and then they create relationship with spokes, which are other federally health FQHCs, federally qualified health programs. There are some Indian health programs that are actually part of the hub and spoke system, the bigger hub and spoke system for the state of California. Individual providers, they can be part of the hub and spoke system. So basically it's developed so that the methadone maintenance program or the hub can provide support and expertise to the spoke sites and provide education and technical support. And then finally, our project, the Telewell Indian Health Program MAT Expansion Project, and that was our project is specifically designated or designed to expand medication-assisted treatment into Indian country via telehealth, and the cost is covered completely by the state contract for the telehealth services. We also provide coaching and mentoring to assist Indian health programs in developing their own MAT programs and integrating traditional health practices into their programs. So in the next few slides, I kind of go into a little bit more detail regarding the three, really the three main components of our project. So there's the educational piece, the webinar, which is what we're doing here. There's going to have some other parts to that, as you can see on the slide. The technical assistance piece, some of you may have been in contact with Katie Bell. She provides on-site coaching and mentoring. And then there's the direct service piece, and we can provide up to 10 hours per month now of direct MAT service. And this is for folks who either want to provide the service and can't develop their own program, or for some other reason would like to have more services. We are almost out of time, so let me check. Let's see, there's something in the chat. All right, so looks like we went in and out on the sound. Again, I'm very sorry about that. I'm hoping that the sound will be on the recording. This is going to be recorded, and so everyone will have access to it after we're giving it. We are going to be repeating this in 2 weeks, and we're going to be providing it to all Indian health programs. There'll be a little less opportunity for the closer interaction. Whoops. Great update thing. Remind me later. So let's see. Let me go ahead and stop sharing and see if there's any other, if there are any questions regarding any of the material, or if you have any questions regarding our project. It looks like they haven't cut us off yet, although they may here in a second. Okay, well, I don't see any questions, so I am going to going to go ahead and okay. That's a really good question. Is there, Julie asked, is there any use of Suboxone for other illicit substances like meth? Unfortunately, no. Suboxone, number one, can't be used for meth. It's not effective for curtailing craving for that. And unfortunately, there's nothing like it. There is some weak research that shows that perhaps Wellbutrin might decrease craving for meth, but I have I've never had a whole lot of success with it, even though I have used it. So when we're going to do case histories, we will make sure that we start on time next time. And so we'll start doing the case discussions following the next scheduled webinar, which will be in 1 month. They're going to be basically the second Wednesday of every month. So that's September 12th. But yeah, we'll make sure that we start on time. We were about 10 minutes late this time, and then we'll have time at the end for case histories. That is important. That's I think one of the most important parts of this webinar. If you have any cases you'd like to discuss, now we can do that. It looks like they haven't cut us off. And if not, I will, as I mentioned, I'll go ahead and bring at least one case to the webinar that illustrate some important facet of buprenorphine treatment. Okay. All right. Well, thank you so much for your participation. Looks like there wasn't a question. Okay, all right, so I don't see anything. So I'm gonna go ahead and end the meeting, and then I hope to see you next meeting. Thank you very much for your participation. Again, this is going to be recorded and will be available afterwards. Okay, thank you, and we'll see you next time.